names in the attendees box. My name is Jessica Schleider. I'm an associate professor of medical social sciences, pediatrics, and psychology here at Northwestern. I'm also a director of digital services in the Center for Behavioral Intervention Technologies here at Feinberg School of Medicine. And I'm really happy to welcome you to our final 2024 edition of the CBITS Digital Mental Health webinar, sponsored jointly by the CBITS team and the Society for Digital Mental Health. Really excited today to introduce our speaker, Dr. Adrian Aguilera, who is an associate professor at UC Berkeley and UC San Francisco. He leads the Digital Health Equity and Access Lab, or dHEAL, and he studies technology-based mental health interventions for underserved populations, specializing in cognitive and behavioral therapies. His work integrates mobile technologies and data science to enhance mental health care personalization and effectiveness, focusing on innovation and equity. We're so excited to learn from you today. And with that, I'll hand it over to Adrian.
Great. Thank you so much, Jessica. Thank you all for joining. Okay. Let's see. All right. So today I'm going to talk a little bit about some of the work that we've done over the past few years, with a particular emphasis on cultural adaptation and community engagement, to really improve the reach of digital mental health interventions. So my research program is at the nexus of developing innovative digital mental health interventions, studying health equity and trying to improve health equity, and implementation science to make all these things happen in the real world. One of the questions that I am motivated by is thinking about who is digital health designed for. And here you can see some advertisements of some major wearables, so obviously Apple Watch and Google products. And what we can see is the folks that are represented in a lot of these advertisements tend to be people who are already healthy and who are trying to optimize their health. And one of the challenges with this approach is that if we continue down this path, it'll be difficult to really have a broad public health impact if we're not working with and for people who have the highest need, and who can maybe increase their, for example, step counts from 3,000 to 4,000 versus from 9,000 to 10,000, right? Proportionally, that 1,000 step increase for folks that have a lower baseline is going to be much more impactful. When we look at access to things like wearable devices, what we also see in the data is that people who already have excellent health tend to use these devices at greater rates. And they likely will benefit from these types of devices, but likely or only marginally so relative to their already excellent and good health, compared to folks in poor or very poor health, who might be able to find some benefit, but aren't using these types of devices for various reasons, either access, knowledge, things like that. Here's another way to look at the data based on age and socioeconomic status. So folks that are younger, higher income, higher education tend to have much higher rates of wearable device ownership. There's some increases happening in the older folks from lower SES backgrounds, but the differences are still quite large. So there's a large access difference from the get-go. We know that digital health apps are also primarily available in Spanish. in English. And that's going to limit access to a wide variety of people, not only across the world, but even in the US, where we have different languages represented. A lot of our work focuses on Spanish in particular. Some of our colleagues are also working on Chinese languages as well to improve access. There's also been some limitations in terms of impact based on how the private industry is developing digital health, where folks that they work with are not necessarily the most high burden populations. There aren't always measures of outcomes, cost, or access. So again, this is going to limit the impact long term of interventions that go to market. And we know that as much as on the research side of things, we do some development and testing, the real implementation is likely going to be from private companies out into the world. We know that there are mental health and digital disparities. We know that racial and ethnic minorities, for example, are less likely to receive mental health services, period. And when they do, they are likely to receive lower quality of care overall. We need to address digital literacy when we think about development and implementation. One of the ways I think about this is many of you may be aware of the MVP idea, minimum viable product, going to market with kind of the most basic version of your intervention, of your product. And I also think we need to think about who's the minimum viable user, who can engage in the tool that we're providing, and how can we develop it in ways so that it can reach people with relatively limited digital literacy. Obviously, we need some level of digital literacy, but how can we lower that baseline a bit? The broad motivation of all of this is that if marginalized and underserved populations are not considered during the development and evaluation of these technologies, they might serve to further entrench rather than overcome disparities. So that's really at the core of a lot of the work that I do. This is from the Digital Health Social Justice Guide that Caroline Figueroa and a group of us developed, where we tried to outline what are some of the key things to consider in developing digital health interventions. And so some of the things to consider are equitable distribution. So who is represented in my research and also just in my product, right? If you're not on the research side of things. Equitable design. So who am I working with? Am I addressing barriers, digital literacy, et cetera? Privacy and data return considerations. Thinking about stereotypes and bias and how that factors into the development of interventions. I think here one of the things we're going to see importantly is as we start to use AI to do more, let's say, cultural adaptation and linguistic adaptation, which I think has a lot of potential to expand availability and access, we have to be very careful to not aggravate some of these biases that exist within, the data sets and just within our society. One of the more difficult things to address in our interventions, since they tend to be individually based, is considering structural racism, structural factors that are impeding people from achieving optimal health. And I think this can be difficult. I think one of the things we need to do is to recognize that this exists, and I think we can do that within the interventions in order to make it real for people. And to also consider whether for some people, structural factors, contextual factors are going to be more important because they may have less choice, less agency in being able to change various aspects of their life. I think we need to really consider those factors as they relate to health. When considering cultural adaptation, here's some of the factors that are important in this work. So this is figure developed by Liz Eustace and some of us thinking about cultural adaptation of technology-based interventions. And a couple of the things to think about are, in particular, one thing about the content of the program, as I mentioned previously, involving individuals from targeted communities and also from broad-ranging communities. One of the things that we really would need to ask ourselves is, who am I developing for? I think we often say, I'm developing for a general broad audience, but that kind of might default us to a mainstream, higher educated, higher SES population. We want to start thinking about how to tailor content. I think this is going to become, again, much more possible with the development of kind of AI tools. So we have potentially principles of an intervention, but the delivery of those principles might look different based to match the user a bit more and make the content more relevant. Support of the program is also going to be quite important. So this is important for again, for adaptation. This is a way to make tools more culturally responsive and also address aspects such as digital literacy. All right, so that's some of the framework in terms of how myself and my group think about these things. So now I'm going to go into a few of the projects that we've worked on to make these things come to life. So the first project is our mood text project, which is kind of the foundation of a lot of the work that we've done. I started this back in 2009, so making me feel old within the digital health world a bit. But what we wanted to do is leverage text messaging to improve treatment quality engagement within group cognitive behavioral therapy for depression. So using text messaging as an adjunct to care. And so the program consists of mood monitoring text messages on a daily basis, measuring mood on a scale of 1 to 9, medication reminders, theme-based text which remind people about the content of the CBT intervention, and then attendance reminders. So folks were getting about 2 to 3 messages a day during a 16-week treatment period. And I won't go into too much detail. Some of you may know about this a bit, but I'll focus a little bit more on newer projects. But I did want to mention kind of this as the basis. And some of the key findings that we found were that patients in a public sector primary care setting who were all Spanish speakers from low-income backgrounds, attended over twice as many sessions when they were receiving text messages compared to when they were receiving standard treatment without any technology-based adjunct. And even more dramatically, they stayed in treatment over 4 times longer. So out of 16 weeks, median time to dropout was 13.5 weeks compared to 3 weeks for the non-texters. So this really shows how texting can decrease treatment attrition, and ultimately we can help more people get better. Obviously, there are different ways that we can deploy digital adjuncts. They don't have to be text messages. They could be apps. They could be other forms of digital communication. But interestingly, I think text messaging, although it's a relatively old technology at this point, does provide simplicity in being able to deploy to a wide range of groups and address some factors related to digital literacy. So I'll talk about some other technologies that expand upon that, but I wanted to make sure to call that out. In that project, also we not necessarily from the get-go, but always have in mind thinking about cultural differences in how people perceive mental health, how people perceive digital interventions. And so we wanted to just ask people how they found the messages to be helpful in the intervention. And what we can see is that people, English speakers in particular here, reported that the messages helped them to become self-aware. Right, which is something we really want people to do. Be self-aware is the first part of changing cognitions and changing behaviors. So we were excited to see that. And Spanish speakers mentioned some of those things to some extent, but interestingly, they tended to mention feeling cared for and supported. much more often than the English speakers. And I think this is really important to consider how the user interacts with an intervention and what users bring to the table. So the result of the interaction between the user and the technology-based intervention is going to be different based on what the user is bringing to the table, even if the intervention is exactly the same. So here, folks were really talking about how they felt cared for and how it built upon the therapeutic relationship that they already had. All right. So after mood text, we wanted to move into thinking about beyond depression. So I was working in a primary care setting where there was a lot of comorbid physical health problems, and diabetes has been a kind of a huge pandemic before kind of the pandemic, particularly in low-income Black and Brown communities. And depression and diabetes interact with each other, but their care is often siloed. And physical activity is a core mechanism for both. And then another motivation is that we want to make sure that these mobile health interventions are personalized, integrated into care, and again, developed with the most needy populations. So both diabetes and depression can be improved with increased physical activity through slightly different mechanisms. For depression, for example, we often might call this behavioral activation. Increased physical activity may be a proxy for engaging in the world a bit more, engaging in social interactions versus being isolated, et cetera. And with diabetes, the focus is more on kind of the physical benefits of physical activity, the physiological benefits, et cetera. And so again, the focus on underserved populations who often aren't the target of these interventions, but experience the highest prevalence and worst outcomes. When we think about personalization, I think a lot of us have different things in mind. By and large, most technology-based interventions are not personalized. We often think about, and the question I often get is, how can we make this product as broadly applicable as possible? So by definition, that's not personalization. Sometimes we do group level or even cultural adaptations, linguistic adaptations, but these don't account for more individual-based differences. And so what we wanted to do is to bring in reinforcement learning, so a type of machine learning, which can allow the prediction of the most effective content for users. So the next couple of projects, I'll talk a little bit about how this can be deployed and what some of the outcomes might be based on how we do the deployment. So first, to explain a little bit of what reinforcement learning is and what our intervention was trying to do. So what we did is we collected step counts from smartphones. And then we also sent folks a text messaging intervention that used data from that step count to change the messages that were sent to improve the outcomes based on which messages were most effective. The messages that we developed were based on the COM-B framework, which stands for capability, opportunity, and motivation, influencing behavior. So this is an implementation science framework that thinks about different factors related to behavior. And it brings together a variety of theoretical frameworks into kind of one model. And it can be helpful because it not only thinks about things at the individual level, but also can think about things at other levels as well. What we did for the Diamante project was started with message drafting, then moved into different phases of feasibility testing, pilot testing, crowdsourcing, review, and then final selection of our messages. So this is all just in the development of the message, the messaging. And I, mention this because it reflects this idea of user-centered design with the community. So we work with folks in these public sector primary care clinics to really get their feedback. And we started with our messages that were based on, the theoretical framework, but had to do some adaptation based on feedback. So, for example, in the motivation category, people mentioned that they wanted things that were a little bit more inspirational, that were relevant to them, that were maybe less repetitive. And then we also wanted to make sure that what was in each category actually reflected that category. This is the app. This is what the app looks like. The app is basically collecting step counts on a daily basis, and then folks would be getting 2 text messages a day, one with feedback about their step count, and then another providing some sort of a message from the COM-B framework, so more of a motivating message to go out and engage in physical activity. So these are, again, the messages, different types of feedback messages, different types of motivational messages. And so now I'll talk a little bit about how the algorithm goes into choosing the messages. So here's some of the terms to consider. So action variables, which is what the algorithm does, contextual variables. So these are things related to, this is data that comes in related to the individual and things around them. Reward is probably the most important for reinforcement learning. So this is the outcome of interest. So in our case, step counts is the outcome, and then the model, how all this comes together to actually come up with an action and decisions that the model makes. Okay, so the action variables are feedback messages. They would get one of 4, so either nothing or something about reaching their goal, just the number of steps yesterday, or whether or not somebody walked more or less. Motivational messages, again, based on the COM-B framework, or no message that day. There's also determination of what time to send, and this again can vary based on what's coming in, whether there are potentially certain times of the day that are most effective for sending messages. And the contextual variables are variables related to what a user is doing, so how many steps they've taken yesterday, the last 7 days, how they're doing with in regards to their goal, personal variables related to demographics, when messages have been sent, etc. So all of these get put together, and every morning the algorithm is retrained on data of all participants. So all this is put together, and a reward is calculated. Reward being steps yesterday versus steps the day before, and then a determination is made about which type of message is going to be sent. So as an example, so the algorithm might predict that a benefit message is going to result in 500 more steps. And it may choose something from that category, but it may choose something from a different category, because there are different combinations of messages, and the model also needs to continue testing which even categories that are not necessarily the most effective. This also provides some variability, so people are not receiving the same messages every day. So we tested this in a low-income primary care clinic with English and Spanish speakers, folks that had a diabetes diagnosis and depression symptoms with varying digital literacy levels, and I would say more on the lower side, with the year design phase that you saw previously. We started recruiting a couple months before COVID hit, so we ended up having to uh, uh, supplement the sample recruiting on social media, primarily via Craigslist. So this provided some challenges, but also opportunities to make some comparisons. Okay, so this is the design of the trial. We had an adaptive arm, so this is the reinforcement learning arm. We had a random arm, which got messages from all of the same buckets and categories, but they were sent randomly and without any sort of algorithm making decisions. And then there was a control arm who got only the app, and we asked folks to track their steps, and then once a week, they'd be asked what their mood was. Here are the participant characteristics. There were no differences, which is obviously important in an RCT. And you can see that the sample is relatively diverse. We have a fair number of Spanish speakers, a range of education, employment status. So we're pleased that kind of this broad range to help the results be a little bit more generalizable. And after participating in for 6 months in the study, what we found is that the adaptive arm indeed resulted in increased steps over time compared to the random and the control arm. So most importantly here is to look at the slope of change. So you can see that the random and control arm are relatively flat, maybe some slight increases over time, but the adaptive arm had a higher increase over time. There were some baseline differences that were non-significant statistically. So again, the main emphasis here is the increase in the slope of change, which we were excited about. So personalization with machine learning can lead to improved outcomes. Testing this in a resource-constrained environment can be relevant for broader populations, and particularly in the age where we're thinking a lot about algorithms and whose data is represented. I think this is one example of the ability to develop algorithms that are representative of folks who have a high level of need. Here's some of, it's a little bit of a busy chart, but some of the things that we need to consider in developing these algorithms. So algorithms can be complicated, or simple, and not all are the same. But some of the things to consider, particularly if you're thinking of developing or using an algorithm in your work, is defining the model for kind of decision making, right? So what are the variables that are going to determine personalization, how much data we need to have so that the model can start personalizing. And probably one of the most important is picking a short-term outcome, the reward, right? So here was step counts, but it could be something else. Ideally, you want a reward that can be updated regularly, that you can get data on so that there can be more movement in the algorithm. You also need to consider data handling and collection in real time. These algorithms can run slow since there's so many processes going on. It's essentially running large regression models with tons of variables in them. And then as we think about algorithm performance versus effectiveness, implementation issues. What are our comparison groups? We chose a random group. We could have just done a control group and just done 2 groups. Part of it is thinking about, are we testing the algorithm itself? Are we testing the deployment, et cetera? So there are a variety of things. And then beyond this, we can do improvements to the algorithm as well. This really requires collaboration, involvement of folks in data science that have the knowledge in algorithm development. All right. During the time when we were running the Diamante project and COVID started, we decided to use our Healthy SMS texting system, which is what we've used to build all of our texting interventions, to do an intervention for managing the stress of social isolation and of the pandemic, generally speaking. So we developed the Stay Well program based on, with the help of Sabrina Darrow and Caroline Figueroa. It's a 60-day CBT and DBT texting program where folks got 2 messages a day with some tip on managing their wellness and also tracking their mood. And what we found after participating in the program, people tended to improve over time. And we also wanted to compare based on ethnicity. In this case, we were able to recruit a significant number of Latinx participants. And interestingly, what we found is that they tended to benefit more from participation in the intervention. So more of them improved over time compared to the white participants. And this is interesting and important because I think it highlights an important issue, at least my hypothesis around why this might be happening, and we can explore this a bit more, is folks with Latinx backgrounds may have less access to these types of tools. So given that their engagement is probably newer and more novel, they may stand to benefit more compared to people who may have already accessed these types of tools, this type of information. And so it's a relatively less novel intervention with maybe more marginal improvement. Here's another look amongst the folks who are moderately depressed. Again, we see more improvement in the Latinx population. Again, this is support for really thinking about broadening our target population. And I really, from a private company perspective, really thinking about what are the untapped markets, who hasn't been reached by these types of interventions. Now, we wanted to, after doing the kind of first round standard Stay Well intervention, which we deployed at the beginning of the pandemic, so we didn't do RCT. It felt unethical at the time. A couple of years passed, and we wanted to look at ways to improve the Stay Well intervention and to see if we can apply the reinforcement learning algorithm that we did in Diamante. And so we followed a similar design in a Stay Well intervention, but here the reward changed where it was mood rating. So the algorithm would decide what message to send based on the mood rating, and then also send a feedback message to folks based on their mood rating so that it wouldn't just kind of sit there and not provide feedback. One important distinction between the algorithm that we used in the Stay Well intervention and this intervention compared to the Diamante intervention is here, it was individually based. So it was based on the data that each user provided and not on the group level data. And we'll talk about the challenges of that. So these were some of the differences that we saw by some decreases. So the reinforcement learner had some slightly more decrease in symptoms of PHQ-8 and GAD-7, so depression and anxiety, but they were non-significant. And so we were trying to figure out kind of why that might be. Here, the symptom decrease for people with mild depression was significant. So folks that don't have high levels of symptoms were able to see more benefit from the intervention. And so there are a few different reasons. So one could be that the algorithm was not strong enough, which makes sense to some extent because it's individually based. If people are participating over 2 months, they're probably not providing quite enough data for the algorithm to learn. So we had some regret of not building a group level algorithm to bring in more data. The challenge is at the individual level, the motivation for doing that is to really think about what are the individual level factors, individual level differences, particularly in a diverse sample. It looks like that individual level difference may not be as important as the group level data that we can gain from potentially. Another possible reason for the difference is that the control condition was folks receiving mood rating messages every day, but not getting the content, tips, things like that. And in qualitative feedback, what we've actually seen is that people find the mood ratings on a daily basis to be one of the most helpful things to help them be self-aware. So it's also possible that the control condition may not be truly a control. So effects are relatively small, so there is improvement over time, but this approach is scalable. All right, and then the last project I want to talk about is something that's ongoing. And it really starts to get us a little bit closer to thinking about community engagement in this work, which I think we need to do more of to make digital mental health interventions more impactful. And this is a little chart that I think is helpful in thinking about impact and how we engage in communities. Oftentimes we do community-informed interventions where this would likely include some user-centered design where we ask people from the community to provide feedback, but they're not necessarily given a lot of influence around what the intervention is or what happens in the intervention. There's community involvement where maybe it's more of a partnership. And then there's community-driven approaches where the community really leads and maybe we can follow and provide support. And again, I fully understand that the community-driven approach is quite challenging for many reasons, but it's really important to think about what our impact is going to be and also what the sustainability is. And if the more we move up towards community-driven, the more likely that our interventions are going to be sustainable. In engaging with community organizations, which we've done for this last project in particular, we went out to a local community organization that started during COVID, and they actually identified mental health as a factor that they wanted to work on. So at least we had a shared goal there. And some of the things that are important are some basic skills around building rapport, right? We often go in with being excited about technology, being excited about interventions, but we really need to remember that the relationship is quite important. We have to be patient and work maybe on a slower schedule. So I went in to work with our community partners to tell them about, our project, and I had an agenda about explaining what we wanted to do, et cetera. And instead of doing that, they wanted to show me around the building, introduce me to people. And I realized very quickly I had to just throw my agenda away and really focus on connecting and understanding and listening. And that just requires flexibility. This community this community collaboration is part of the Subeda project, which is a project looking at how to provide digital CBT to Spanish-speaking participants who have a challenge accessing care from Spanish-speaking providers, and to provide support from people within the community, which we're calling peers. They're not peers in the sense of peers with lived experience necessarily, but they are peers from the community. So these are people similar to kind of a promotora type model. So people that don't necessarily have a bachelor's level or formal education in health. And we also want to test different implementation strategies within a primary care setting. So what the Supera project does is evaluates the implementation of a digital CBT intervention, Silver Cloud namely, in safety net primary care clinics for Spanish speakers with depression or anxiety, paired with community supporters. So here's a photo of our community supporters working, learning to use the platform to provide feedback to patients. The way we designed the study is to compare peer-supported digital CBT compared to standalone, and then to also compare two different types of implementation. So one, which would be outreach via patient registry, and another, which is we're calling inreach, which is more of a warm handoff model or provider referral. So in this case, in this clinic, there's a behavioral health team. So we worked with them to look at their referral list, and we can reach out that way. And so this is helpful to think about if these types of interventions are successful, what are the best ways to implement them? The most efficient ways? What are the pros and cons of an outreach approach versus an inreach approach? So we're using Silver Cloud, which has been tested in a variety of research studies and is one of the few programs available in Spanish. And it's a standard CBT program that lasts 8 weeks. As part of the process of training community members, we worked with them for about a year to get them familiar with the program. And we also then asked them who wanted to be supporters. And a group of them did not opt in to be supporters. And we wanted to understand them and why that was, and to provide some feedback. So they, on their own, developed a participatory action project to give us some feedback as to what were some of the reasons. And we found that to be quite valuable in terms of improving the intervention. We also looked at our community supporter trainings to identify some of the key issues from those trainings. Okay, so for the PAR sub-study, so what people told us were barriers to participation were reading difficulty, limited digital literacy, anxiety around technology, which is probably paired a little bit with the previous one. Discomfort providing mental health advice. So this is more personally not feeling maybe equipped or appropriate to provide mental health advice. And then the challenges of personal obligations. It's important to note that while we're paying our supporters, they're working, we would say, about maybe 4 hours a week at this point, 4 or 5 hours. So it really has to be kind of above and beyond whatever other things they have going on. Some of the solutions that they recommended were to simplify language. So this is something we have to continuously work on. As I mentioned, it's part of the minimum viable user idea, right? How simple can we get our ideas and still get them across? Have content that's reflective of the community. People want to see themselves in the content. And we did change some of the vignettes, for example, that reflected stories that are more relevant to immigrant context. And then they wanted more multimedia, which, again, I think eases the need to engage in reading, which people if they don't have high levels of education, it's not something that comes as natural to people. And then for the community supporter training, some of the things that we had to focus on are obviously practicing working on the tools, understanding the CBT model. A big emphasis, and I think maybe a point of anxiety for people are often the role clarity and their expectations. So supporters often want to do more. They asked us whether they can connect with patients in person, whether they can speak to them more often, things like that. And so we really have to clarify how we see the project, and we have to explain the role of research and standardization, things like that. There's a lot of discussion around confidentiality and ethics, which is also part of kind of risk management, boundary setting, et cetera. So many of the things we might discuss in a standard supervision for mental health providers, right? There's been a fair amount of technical and language literacy, which is a big barrier to engaging in these types of tools, but I'm really happy to see the progress. When we started, we gave each supporter a laptop to provide feedback to patients via the platform. And many of them had a hard time just logging into their computer, just those basic steps. But through repetition, through practice, they've really gotten the hang of it and are just doing really well. And I think it's a testament to the fact that if we spend time to do some upfront training, there can be benefits over time. Right now, a lot of this people are talking about digital navigators is doing some of this, and I do think it's really important to invest in that in order to have stronger implementation. And then as a general kind of supervision session, there's team collaboration, feedback, and also just rapport building within the group, right? We bring food to meetings, we do a yearly celebration. We want to make it not just work, but people are doing this not for money necessarily, but because they care, and we also have to show that we care as well. So I'll end there and just really want to thank obviously funders of this work and all of the many people that help make this work happen. I think we can open it up to a few questions now. All right. I see there's a few in there.
Thank you so much for sharing. I can read out some of the questions that folks had. People were super engaged, so thank you, attendees as well. First question is from Paige Anderson. Great presentation and great work. You've mentioned AI a couple of times. What are your thoughts about specific ways you can imagine AI being used to help with cultural adaptation? And two, on what data will AI models be trained?
That's a great question, and I didn't present it this time, but we are working on a project with Jason Satterfield where we're developing a pain app for various cultural groups, and I'm helping with a Spanish adaptation, and we've started using some AI tools to do not only translation, but doing some adaptation as well. So there's kind of the base content, but these tools can, so in our case, we started with ChatGPT and have tried different ways to provide prompts to get data that's get content that's more reflective of users. The nice thing about this approach is that we can think about reading level, we could think about what types of countries people might come from to consider dialects. We can ask it to include maybe some more specific cultural sayings or content. And again, the output is not perfect by any means, but it really speeds things up so that instead of having our team do the development from start to finish, they can get a head start and edit based on what some of the AI tools have done. So I don't think we're at a point where we can say, okay, just hit AI and start personalizing to everybody, but I think it can get us quite a bit farther. The challenge with the models is that they're just so opaque right now. So we're kind of we're taking a little bit of a leap of faith. The thing we have the most control over is providing good prompts, and then just kind of testing them repeatedly until we're getting content that is more reflective. And so with that, we still need people within teams that really understand the communities that we want to reach.
Perfect sense. Next question is from David McCord. Very impressive intervention and equally impressive research agenda. My question has to do with a step earlier, the point at which potential patients or clients might be referred. That is, have you considered systematic brief screening instruments for deployment in primary medical care that would efficiently identify individuals who would benefit, appropriately culturally responsive?
Yeah, that's a great question. Screening is very important. It's something that the system that we're working in is doing a better and better job of deploying PHQ-9s for screening. So that's what we're using as the basis for going into the clinical record and for getting referrals primarily. I think that screening is really important, but I think there's a delicate balance because there's a big push to screen, but then we have to make sure that we have something for people, I think, after we screen them. Otherwise, we're just identifying a lot of need and not addressing need. So I think I think both have to go hand in hand.
Next question is from Gio Ramos. Regarding the study suggesting that Latinx users benefited more from the texting-based interventions compared with white users, were there any differences in baseline symptom severity? Finally, would it be possible that the differential effect observed among Latinx participants is led by higher engagement with the text messages rather than novelty itself, given that these participants finally, there were quotes in this, got access to any type of mental health service, while white participants might have had access to other potential wellness apps or services? In other words, is it novelty or engagement or something else?
Yeah, that's a great question. And I think so. I don't know the exact numbers, but overall, I don't think there were big differences from baseline mental health symptoms. And even when we broke them down by categories, as I showed, there were quite big differences in terms of resolution of some symptoms over time. And I think that a lot of it does have to do with access. I think kind of novelty and access, in my view, go hand in hand. Things are novel because they haven't been accessed before. And so I think the more that we can go to places where people don't have access, the more benefit we're going to get. I think oftentimes people who go into mental health studies and interventions are kind of interested in wellness. They've tried different things. And what I think often get is we get people who have just tried a variety of things and want to try something else. And so some of the content, some of the ways of thinking about these things are not that unique. And people have told us, like, this content was not that new to me. I already knew this stuff, right? And that's great. And what that tells me is we have to go to people who don't know these things, because there are a lot of people who don't know some of these basic things, right? So I think access is a key part of it.
So a few more questions. We only have a few minutes left, but I'll try to get through them. For the Silver Cloud project, were the community supporters acting as the Silver Cloud coaches, or were there other mental health professionals in that role from the health center?
Yes, great question. So yes, the community supporters are the Silver Cloud coaches. So we're doing that instead of mental health professionals. A lot of studies have looked at mental health professionals as coaches, which I think can be a great approach. The question is, how sustainable is that, particularly financially, compared to community supporters? So the good thing is we can do a little bit of comparison based on previous work.
One question from Alex Hogios, my awesome colleague here at Northwestern. The vast majority of our digital health interventions are text-based, but today people get health information from multimedia formats like short videos on social media. How do you think about the text-only modality in relation to health equity? Should we evolve beyond text-only interventions to video-based or photos to align with where and how people seek information today?
Absolutely, yes.
Hey,
Uh,
the answer.
yes. Yeah, I think that the challenge is, and part of it is, right, our own bias of using text, and we rely on text, and so that's what we do. I think the challenge on videos, is the production of these things, right? But we do have to think about where people are. And I've always, really thought, I think one of the reasons that text messaging, for example, has worked relatively well is that it's where people are. People use a text messaging app every day, right? Whereas if we build them a new app, we have to do so much work to get them to that app. People use TikTok, right? For better or for all, it's good and bad. And that's how people are used to engaging. So I do think that we need to think more creatively about how are people taking in information now, and how can we get into that stream uh, to help teach people some of these tools and to kind of maybe balance out the streams of it as well.
So we just got, I think, an interesting question that may be of interest to our attendees from non-academic spaces. A broad question is how to better understand the industry landscape, as in how is equity and community engagement research being merged with the private sector, or is it being merged with the private sector? And how can the private sector be influenced to prioritize these things?
Yeah, that's a great question. I think we have to recognize that there are different push and pull factors. Uh, and in private industry, the main factor is finances and generating profit and staying alive and growing, right? Um, but I don't think that that is necessarily at odds with equity. Uh, if you think about it from market-based perspective, right? There are many untapped markets that also have high levels of need. So I think there needs to be a lot more work of connecting with communities, of going out into these communities. In some ways, private industry needs to do implementation science in a sense, right? Go out into the world because that's where I think they're going to see some real benefit versus going back kind of to the same well and getting marginal improvements.
All right, we're about 30 seconds out from being at the hour. So unfortunately, we can't get to all the questions today, but thank you so much to our very engaged attendees. And thank you, Dr. Aguilera, for presenting this amazing work with us. We all learned a ton and grateful for you sharing your ideas and perspectives.
Thanks for having me. Thanks everybody for attending.